I thought I'd start with just an update on the current status of health reform. So much is in the on the nightly news and in the paper and stuff like that, and there's a lot of flux. I'm going to present as of today what's going on, but I first wanted to give a backdrop, and I need to give a disclaimer. Our health system is neither politically right nor left. And what I share with you is simply facts as I see them. But the current Affordable Care Act, sometimes simply the acronym of the ACA, many have been critical and many have praised the Affordable Care Act. Those that praise it call out the pros that millions of uninsured now have insurance, particularly through the Medicaid expansion. In California, 1/3 of all adults have health insurance through Medicaid. We call it Medi-Cal. And 50% of children in California are insured through Medi-Cal. I'll just continue going into the pros. The electronic health record has been a boon in order to keep records secure and also make them available to other health systems. Preventive health has been an emphasis. Covered California, which is the healthcare exchange in California, has made it easier to access and have affordable premiums. The individual mandate and business mandate with penalties has made it so that more people buy insurance who didn't have insurance before, and then when they access the healthcare system, they didn't have any insurance at all and often receive free care where others had to pay for the insurance. And finally, guaranteed issue, meaning that irrespective of pre-existing conditions, an insurance plan was required to issue insurance. Also within that same category as young adults up to the age 26 would be able to get insurance through their parents. So the cons of this, almost the corollary is while millions have insurance, the cost has been greater than anticipated. The original savings were projected to be $143 billion, and the projected overage is about $1.7 trillion. And so we missed the mark on what it was going to cost us. And also what's controversial is states now must start picking up the cost. For the state of California, it has to pick up this year in 2017, $1.6 billion of the cost, and next year, an additional $1.6 billion, and each $1.6 billion represents 5% share. So as Medicaid has expanded, the first few years were completely funded by the federal government, and now states are having to pay a small but greater portion and growing portion of the cost of the expansion. There have been, with electronic record, there have been frustrations with costs, and many physicians would say that the electronic health record has made them less productive in the office. Some describing it as 20% less productive, and some physicians are frustrated they at the end of their day, they still have to do electronic charting, and they take that home with them, and so it's a frustration. So both a pro and a con. The preventive health emphasis has resulted actually in higher costs, both short-term and some project long-term. There have been higher deductibles, rising premiums, and many employers have dropped insurance, and employees have instead gone to the exchange. And not in California so much, but throughout the country, there have been many health insurance plans that have dropped out of the health exchanges, and sometimes only one insurance plan has been left, and that has enabled that insurance plan then to have extremely high rate increases. In one state in the Midwest, it went up by 108% from one year to the next. In California, it has not been that, but there have been in the last year higher than anticipated increases and hikes in the double digits for the insurance plans. In terms of the individual mandate, which many think is a good idea, many disagree as strongly, feeling that the penalties are too low and that there's a loss of choice. And so there's a rising cost of insurance through taxes because of guaranteed issues. So depending on your perspective, many would say that the Affordable Care Act, also called Obamacare, has been a real success, and others would shout as loudly that it's been a failure. We need to keep it. We need to get rid of it. And so this is really the source of the commentaries on the nightly news and so forth. There are these divided opinions of whether it's good or bad. From the Hospital Association standpoint, again, we're not political either way. Our belief is that when the Affordable Care Act was first passed, it was largely done swiftly for political reasons, and we could have done a better job in planning for things. Now, equally, there is an equal opposition, and it's now political to repeal and replace it with something without real secure planning. Now, what's in the bill right now? And I realize this is a very busy slide, but trust me, I took a lot of information and crammed it down into what I thought were the most salient points of the current bill, which is called the American Health Care Reform Act of 2017. And I'll talk a little bit more about how this would go into effect, if it's going to go into effect, and give some comment on that. First of all, if passed, it's been passed by the House. It then needs to be passed by the Senate. We'll talk about that in a second. It would amend the Affordable Care Act effective January 1st, 2018 by eliminating funding. So it doesn't remove the act, it just takes away all the funding for it. So in essence, it is no longer viable. It increases funding to community health centers. For example, we have Clínicas de Comunidad Real with us tonight. It would increase health centers. It also would increase funding for maternity and newborn care in 2020 and beyond. It would provide age-based tax credits for those earning $75,000 or less as an individual, or $150,000 with joint filers. It would eliminate federal funding of Planned Parenthood and other similar organizations for 1 year. This is both praised and censored in the media. It would eliminate federal funding of additional Medicaid patients after 2019. In other words, the expansion of Medicaid could continue after 2019, but the states would have to pay 100% of the cost of that expansion. So practically, a state could not do that. It would no longer expand. It would keep everybody currently enrolled, and enrollees can continue to go, but through 2019. But after 2019, Medicaid would be fixed, and you couldn't add additional individuals, at least adults. Regarding Medicaid eligibility, the adult eligibility would increase from 133% of the federal poverty guideline to down to 100%. Lottery and gambling winnings would be considered income in determining Medicaid eligibility, okay? I think the Obamacare simply forgot that, and now this has been put back in. This is non-controversial, but it's put back in. This is somewhat controversial. I think people on both sides of the aisle would agree that there has to be some test over time, and this bill would require re-eligibility, redetermination of eligibility every 6 months, okay? And that would be for somebody who is below a set income. If they received a job that paid income, the federal government is saying you have to retest that, and so every 6 months. Now, the problem with that is some people would drop out, would not go forward and get go through the process of signing up again, but this would be a provision of the law if passed. There's been, this is also controversial, some, again, pro and con. This would allow states to impose a work requirement that somebody would have to seek a job and find a job to remain eligible for Medicaid, except for pregnant women or single parents, et cetera. It would also give the states the option for Medicaid block grants versus the current method of funding, which is by formula. Instead, it would simply be, state, you get X number of dollars, here you go, and administer the Medicaid program any way you wish. Some states would want that, and this gives them the option to do so. It raises the contribution limits and expands the uses of the so-called HSAs, the health saving accounts. So an individual who wanted to contribute to that, they could do that with pre-tax money. They could keep it in the bank. They could use it for multiple years, and they could use those dollars to buy things, an expanded list of products and services, and they would be able to use tax-free money to do that. Do you understand what the health savings accounts are all about? Health plans may lower premiums for group health plans and the cost if someone participates in a wellness program. So insurance plans would be able to give an incentive, which is not allowed under the law right now. If somebody entered a smoking cessation program or wellness or exercise, they could be given a lower premium and pay lower copays if they strive to be healthier than someone who did not. And it would also allow states to relax guaranteed issue mandated for pre-existing conditions. This has been somewhat mischaracterized in the press, where the bill completely knocks out guaranteed issue. That's not true. The federal law would require guaranteed issues. However, it would allow the states, if they passed legislation, to change that. And so there's a weakness in that if a state decided to change that law or have a state law that superseded the federal law is what I'm trying to say. This was actually an idea that was put forth by the proponents of the Affordable Care Act, Obamacare, but did not get included in the original bill, and that is federal courts would have jurisdiction over health care lawsuits instead of the local superior courts, and it would have a provision, if passed, that independent review panels, medical review panels, a group of physicians would be a medical review panel, they would determine whether clinical practice guidelines were followed. And if they were followed, the provider might be exempt from certain penalties if a lawsuit was successful, okay? This is an effort, again, controversial, depending on your point of view. This is an effort to reduce the number of lawsuits where a clinician practiced good medicine, but something bad happened outside the control of the physician. Okay, so it is something that Tom Daschle actually promoted many years ago, and now it's an idea that's caught on. And this is something. Now, there's many more provisions of this, but I try to take a thick document and reduce it down to the salient points. And I can come back to this if you have questions at the end. So the Congressional Budget Office, which again attempts to be apolitical, has tried to assess what this would cost, the increased cost or the reduction in cost, and they've determined that there would be a $337 billion savings over 10 years. That seems like a lot of money, but it's not a huge amount of money. And there would be cost reductions of $1.2 trillion, but there would also be tax reductions of about $900 billion. So it saves the American people a significant amount of money, $900 billion as an aggregate, but it reduces the federal deficit only by $337 billion, okay? It would also, its projection, as they looked at it, economists from the Congressional Budget Office believe that this could, in fact, increase premiums in the short run, but then reduce them after the year 2020 because of the incentives and so forth. Okay? Now, the way a law works, as you know, both the House and the Senate, a bill can start from the Senate and then go to the House, or it can start from the House, as most do, and then go to the Senate. And so there was an executive order issued by the White House on January 20th. In March 6th, the House initially released the bill, and they tried to pass it quickly in March, but it failed. And then they did some adjustments, and the final bill was introduced March 20th. It went through a process of debate, and the House passed it earlier this month on May 4th. The bill now goes to the Senate. Now, there's a provision, and this is how the Affordable Health Care was passed. There's a provision that if a House bill and a Senate bill are very similar intent, there's a process called reconciliation, where the House and the Senate come together with committees and try to reconcile the relatively small changes. If that happens, then the Senate only needs 50 plus one vote to pass it. That's how the Affordable Care Act was passed, through reconciliation. Otherwise, if there's wide disparities, then it requires a 60 vote passage, 60% or 60 senators to pass the bill that if there's a difference in them. Do you understand what I'm trying to say there? So now the Senate is in the process of looking at it. I'm not an expert on this, but I have heard the same reports that you have, that the Senate doesn't fundamentally like this. It's not an easy thing for them to simply pass. So there's going to be a back and forth, and it remains to be seen if the Senate will come up with something completely different and pass that and then kick it over back to the House, or if they'll try to work out something where these two bills can be similar enough that the reconciliation process and the rules for that would allow a 50% plus one vote. Now I'm going to turn the time over to Stan. We can come back to this if there's any questions. Dr. Froschwag, I just want to make sure they spelled your name correctly. They have, okay? So Stan, turn the time over to you.
Thank you very much for allowing me to speak to this evening. You know, I'm a little frustrated because I told them that I had a lot to talk about. I needed 2 to 3 hours, and they've only allotted me 20 minutes. So I'm going to give you an overview, try to have you understand the excitement that I feel and that we all feel at Community Memorial Health System, let you know what's happening. So hold on. I'm going to touch on a number of topics, and the things that I want to most communicate are: one, what our specialty services are, the things that are life-saving, critical services, just part of the many services that we provide. We'll go over the outreach services, such as our Health Aware and our lab and where we're located, the residency training program, which for me is one of the most exciting components, and I'll explain why this is so important to you. Our community-wide electronic health record, and as Gary mentioned, there are ups and downs with that electronic health record. I currently use that record, and I will tell you, I think the benefits far, far outweigh in our current health system and health environment far more than the negatives. And finally, I'll describe briefly some of our partnerships which allow us to provide the robust care to our community, you all. First of all, a lot of people don't understand, because we hear so much about the large medical centers, that 87% of all the hospitals in the country are community hospitals. Community hospitals are the backbone of the care provided to all of our communities. Now, we really provide the bread and butter kind of care. In fact, we have UCLA training physicians coming up to Community Memorial Hospital to learn how to do gynecology and gynecologic surgery, because we have more day-to-day type of operations than UCLA has. And so they're very grateful for that. Now, don't get me wrong. If you need a liver transplant or a heart transplant or have an exotic type of rare illness or problem or cancer, we definitely refer our patients to UCLA or Cedars-Sinai or USC or any one of the tertiary care centers. But those referrals are few and far between. The life-saving specialties that I'll review with you in a moment are the brain surgery that we can care for with our two young, contemporarily trained neurosurgeons, Dr. Westra and Dr. Dorsey. We have oncology services right here in town, and those services are provided to our patients without having to travel long distances. It's already difficult, as you know, when you're having treatment for cancer, to tire a person out. And with these services locally available through oncology, through radiation oncology, through gynecological oncology, why we can provide that cancer care right here. And I'll show you some pictures on that. Probably one of the most exciting new areas are the cardiovascular services that are available and provided. We have an open heart program more than 35 years old right now. And the excitement is that we'd have two young surgeons. Actually, they're not as young anymore as they used to be. And my age, I think of them as young. They're getting on. One has been with us for over 30 years, the other 22 years. So they're not that young. We have also advanced cardiology care. And this is probably the most exciting area. Why? Because bypass operations that our cardiovascular surgeons do are operations that require opening the chest. As you might imagine, that's a little uncomfortable. But now we can provide services by passing catheters into the vein that travels into the heart, and we can correct electrical arrhythmias or electrical problems with the heart. One of my good friends had some atrial fibrillation you've heard about on television because it requires anticoagulation, thinning of the blood, and he went to one of our electrophysiologists. The two that we have on board are Dr. Jonathan Dukes and Dr. Ishu Rao. He went to the electrophysiologist. They passed the catheter out, ablated or eliminated the irregular heartbeat that held him back, prevented him from doing everything he wants, and he's doing wonderful now. In fact, I took a backpacking trip with him recently, and it was absolutely amazing to see a person who was relatively disabled, and then after an evening in the hospital, was cured. In addition to that, our cardiologists nowadays, instead of doing bypass surgery, will do coronary artery stents, where you pass a little catheter into the arteries that surround the heart, dilate the artery, put a little canal in there called a stent, opens it up, and for all practical purposes, you're about as good as new. A CardioMEMS is a very exciting new thing. We have a problem, as you might know, with congestive heart failure in a lot of people. And the CardioMEMS is a tiny little device that we slip into the heart, also through the vein. It rests in the pulmonary artery that measures the pressures directly within the heart. You take a pillow that has a receiver, put it up against your chest, and that information is sent via Wi-Fi to your cardiologist. And we can prevent rehospitalizations, which are common with congestive heart failure, in those patients that are brittle, and thereby avoid those rehospitalizations, the cost, the discomfort, the inconvenience to the patients. Finally, an amazing thing for me is the atrial septal defect and the patent foramen ovale. These are little holes in the atria of the ventricles. And sure enough, between the atrium, we have a septum, and these are little holes that people are born with, and we can now go through the vein and patch that little hole without ever opening up the chest. That is very exciting. Now, watch your news channels, and you'll see as we go forward in the next couple years, as much as we've talked about heart problems, stroke is the future, because we can now intervene, and if a person comes in promptly at the first signs of stroke, we can help stop that stroke, reverse it very often with the administration of certain medications, and we are now planning to open up a stroke intervention center over the next year when we move into the new hospital. This is Dr. Dorsey, one of our two neurosurgeons that spend full time at community hospital and provide us with brain surgery, spinal surgery, and peripheral nerve surgery. Peripheral nerve surgery is an area not many people understand or know about, but they are expert in that area. This is our cancer center. Most of you know it. It's right across the street from Community Memorial Hospital. And in this building, we have multiple services for cancer care, which include the oncologist, the radiation therapist, and the GYN oncologist. Good Dr. Bushnell on the left there, and Dr. Dominic Tedesco. These guys are our heart superstars. I can see a couple of you mumbling to one another because they have saved many lives, I'm sure, in this very room, or if not yours, your family members and such. These two have been on call continuously every day, sharing call, alternating for over 20 years now. And I remember working with Dr. Dominic Tedesco 35 years ago, upwards of that time. So I'll tell you, these guys are incredibly reliable, and the statistics they have on outcomes, and I think you understand what I mean by outcomes. That is to say that statistics on outcomes that we have are equivalent or better than any in the country. So we're at the top notch as far as the kind of results we get to see. This is Dr. Ishu Rao, and I mentioned he and Dr. Jonathan Dukes run our electrophysiology lab and provide that miraculous electrical, these are the electricians of our hearts. And finally, Dr. Tom Kong, the director of our interventional cardiology lab and cath lab, and he has been in this role for many years now. His father was an old friend of mine, a cardiologist here in town, and so he's been here his whole life, and he's a wonderful asset to our community and our patients. What I really want you to understand is that we are providing services throughout the West County, everywhere from Fillmore, Ojai, East Ventura, Oxnard, Camarillo. These are just some of the areas. Give you a sense. Those of you who do not know about the Wound Care Center, I've been a family doctor in this town for the past 40 years. I can't believe it that I said that. And I will tell you, because of the Wound Care Center, the type and the excellence that has improved in the care of wounds, in the prevention of loss of limbs, has dramatically changed because of our Wound Care Center, our hyperbaric chambers, and the expertise of Dr. John Tessman, who every one of my patients just loves. The Santa Buenaventura Urology Center is currently doing truly groundbreaking work that I thought was only available in LA, but now I find out active surveillance for prostate cancer, which is an amazing new approach to treating prostate cancer, and they're truly amazing. We have in Santa Rosa Health Center providing care to our Leisure Village patients out in Camarillo. And so, as you can see, we're available across the board. I could keep on going. We also have many other outreach services available. Palliative care is very exciting. This is an area some people don't know about. People who have illnesses that are chronic, somewhat disabling, but the patient doesn't want an intervention, doesn't want you to do too much, but would like to enjoy their life. We know how, through our palliative care program, to set their medical care up so that they can enjoy their life without excessive intervention. We are also one of the very few, many places have inpatient palliative care programs. We're one of the very few that provide outpatient palliative care. We also have our new Parent Resource Center, which new mothers are often hard-pressed to figure out what to do with their baby. And our Resource Center helps them walk through all the steps on how to cope. And it's such peace of mind to our new parents. I will tell you, this is truly a wonderful thing. We have our Health Aware program. In fact, this month is May. It's Stroke Awareness Month. And so last night, I went on and I took the stroke assessment test. It takes you about 7 or 8 minutes to take. I would recommend you go online to cmhshealth.org and take the test in which you think you might benefit. Heck, take them all. If you are deemed by the results of the test as being high risk, You can make a call to the number provided, and you will be further assessed by a specialty care nurse who can then recommend further testing, labs, possibly other tests, and then refer you to the right source, your own family doctor, if that be the case. So this is an exciting opportunity for outreach as well. Now I'm going to go into the area that for me is in great part remarkably exciting and has changed the whole face of Community Memorial Health System. We have residents that we have started to bring on 5 years ago. We're going into our 5th year now. And these are residents who rotate, who take care of all our patients at Community Hospital with the guidance of their attending physicians, senior vintage physicians who will be able to transfer that fund of knowledge to the younger physicians. But I'll tell you, it's a two-way street. The younger physicians bring the latest techniques and style of practice from around the country to from different universities and help us understand how current medicine is practiced elsewhere as well. These physicians rotate at Community Memorial Hospital and Ojai Valley Community Hospital. And the beauty of going to Ojai Valley is once they go to Ojai Valley, very often they're highly attracted to look for a position there too because it's so beautiful. Now the benefits are that we grow our own because of the severe deficit of physicians that exist across the country, and particularly in family doctors and internal medicine doctors, primary care. We are now producing our own physicians. They are fully supervised by the attending faculty, and they raise the quality of care because they inspire the senior physicians to raise the bar, train, and think twice about what they tell the young physician to do. Currently, we have 4 residency programs. We started with 3. We started with family medicine, family practice, internal medicine, and orthopedic surgery. And then the following year, we added general surgery. Currently, starting in July, we have new residents coming on. We're growing from 51 to 63 or so residents with a projected total after we're fully completed of filling all our spots to somewhere close to nearly 90 residents. It's really an exciting time. These are our 2016 residents. They're a wonderful bunch, and we're a mere month and a half away from our 2017 residents who have been selected. These are some pictures of them, and they continue their training. These are a bunch of our orthopedic residents. You notice how big they are? And these this is a picture of the fact that different from my time in training, every resident is required to do medical research and to publish. And here they are presenting at a conference with our 2 senior general surgeons to help propagate that knowledge, medical knowledge, and discoveries that they make. Now, this is probably the most important thing I tell you, because not a week goes by that I am not asked, excuse me, Dr. Frostwijk, could you refer me to a good family doctor? Well, that's about one of the hardest things to do nowadays, but I'm going to give you a hot tip. First of all, the Consumer Reports a month and a half ago came out and said choosing a primary care doctor is one of the most important health decisions you'll make. Unfortunately, it's very difficult to figure that out. I'm going to give you the secret, okay? Get ready. A year and a half ago, you might recognize this good-looking guy right there. A year and a half ago, we had an opening of the family medicine and internal medicine training clinic, and I brought all my patients over there, and they love it. And we have now a place to train our young doctors. So what does that mean? That means these are the attending doctors, the senior physicians who help train these young doctors. And these young doctors give you an opportunity to say, hello, I'd like to see if I can get set up with a new young doctor who I might be able to develop some mutual trust, a long-term relationship that'll provide me with continuity of care, be the quarterback, and coordinate your care, and finally, develop that mutual sense of responsibility and commitment. Now, that's a magical formula, but you can have a piece of that. You can call, select a resident. You can ask, are you planning to stay in the area? And then we do accept most insurances. These are the service provided by family doctors. I will tell you, it is replete and comprehensive, as you can see. What I also like to note here is that once you pick your family doctor there, set that relationship up, you can see we're the farm team. We're going to send these doctors out after 3 years. We're going to encourage them to stay locally in our community. We're going to ask them they're being asked currently by Kaiser, Seaview, Primary Medical Group, Clínicas del Camino Real, private practice, and our own Centers for Family Health. They're trying to recruit these young doctors to stay with them. So when they stay here, you can go to that clinic and you can see them there and continue that relationship. As I mentioned, have been here for 40 years. I started my residency 40 years ago, and I still take care of patients that I took care of 38 years ago. So I'm not telling you, I'm not making this up. This is the truth. Again, our clinic system, as you can tell, spans the breadth of West Ventura County, and they are the Centers for Family Health, where we provide specialty services with cardiologists, rheumatologists, dermatologists, every ologist you can imagine, including the predominant doctors, which are primary care doctors, internists, family doctors, the very ones we're graduating out of our programs. And I would encourage you to do that and go there. And we have, as you see, Ojai Multi-Specialty, and we have a new Ojai Midtown Medical Group where our residents train. These are some of our centers, some of our attending physicians. There's our rheumatologist, Dr. Cheng. Further areas throughout the West County. Finally, I'd like to just mention our electronic health record. I'll be very brief about this. I think my 20 minutes is nearly up. Why is the electronic medical record so important? Because I, as a physician, can access this anytime. It allows me to communicate readily with other physicians. I can fax electronically, directly out of the electronic record, and obtain that information. When you show up in the emergency room in the middle of the night, any one of the 200 doctors who use this across our health system, we can access that information. So if you're being cared for by one of our doctors through any of our systems, you can be evaluated electronically, and that can make the difference between life and death sometimes. Knowing that medication, knowing that allergy, knowing that surgical history, it's critical. I can't overemphasize it. And finally, when I write a medication to which you have an allergy, and I do that accidentally, the electronic system stops me. Says, hey, are you sure you want to do this? This patient has an allergy. Exciting times. I'm going to ask you all who are involved and come eventually to sign up with our portal so that you'll be able to get your labs personally through the internet. As I said, these are all the areas currently, and there are more being projected, that use our electronic health record. So if you recognize a name, if your physician is part of this, they share the record with us, which means that we can access care with your permission in evaluating you in various settings. Again, what is our most important resource? Our staff, our people, our nurses. That's what makes the difference in our system. And last year, nearly 500,000 people were the ones that we treated in Ventura County. And we're here for you. Thank you very much.
Stan, thank you. I'm going to now cover a few more things on the theme of people. We have the best people, and I'm so fortunate to work with them. We first of all have members of our auxiliary. We have nearly 400 active members of our auxiliary. We could not pay for what they do. They staff the front desk. They are in our NICU, cuddling babies. That's a fun job. They're in our pharmacy, delivering medications throughout the floors. They do a tremendous job. I see a couple of the members of the auxiliary here tonight. We also have a spiritual care team. We have paid full-time chaplains in the hospital. But in addition to that, we have a team of spiritual care clergy, if you will, representing almost every denomination in Western Ventura County. They come as volunteers to meet with patients of their faith tradition, and it's a wonderful service that we benefit from. We have two foundations. We have a foundation in the Ojai community, and we have a foundation in Ventura, and they serve voluntarily to boost and encourage giving and how resources should be allocated. And finally, we have 21 volunteer members of our Board of Trustees. You're going to hear from Bill Kearney tonight, one of our trustees. And these individuals spend hundreds of hours. The only thing they get of benefit is we feed them lunch once a month. But we could not run our health system without them. We have over 2,200 employees. That number has increased by about 200 in the last 3 years. It'll increase another 160 as we move into the new hospital, and we're very pleased about that. We are the largest private employer in Western Ventura County. We have nurses, we have pharmacists, we have medical technologists and the rest. And I know about half the names of everybody by first name at least, and they are a joy to work with. We have over 850 nurses in our health system. We just had Nurses Week last week. This is a celebration recognizing the value of nursing, and we have a full-day event, and it's fun. There are skits. If anybody wants to go onto YouTube, they can see some of our skits that they did, and it's a marvelous group. These are very talented individuals in different specialties. Nurses have specialties just like physicians in critical care, in maternal and child health, and pediatrics, and the operating room, and the cath lab. So a nurse is not a nurse. Of course, we have many partners within our health system with the clinics, clinicus, our skilled nursing facilities, and we just honor nursing. We have a collaboration with our local schools of nursing at Cal State University Channel Islands, and also the Ventura Community College District, training programs, and then we have residencies and nursing programs as well. We take newly graduated nurses and we put them through a program where they rotate for about 6 months in all of the specialties. And the nurses are able to see them and kind of assess their talents. And the nurse who's in the training program kind of finds their own tribe, so to speak, and say, you know, I really love operating room. I really like the emergency room, and it works out over the years. Wonderful program. This logo, by the way, was developed by our nurses. I don't know if you can see it, but it's a nurse surfing with our logo, and these are all hands supporting that nurse. We also have the generosity of Barbara Meister, who puts on a nursing scholarship every year, enabling 2 and sometimes up to 4 nurses who otherwise would not be able to pursue a degree in nursing. And she makes it possible to pay for tuition and some other support. And these are just our most recent graduates. Many of you remember Peter Gall, a heart surgeon and a vascular surgeon. We loved him, and he loved dogs, and they loved him. And so in honor of Peter, we have a pet therapy program where these very well-trained dogs come, and they gladden the hearts of some of our patients. They're clean, they're disease-free, and they really make a big difference for some patients. They're very well trained. Here's one of our volunteers and the dog. I want to go to quality really quick. This is patting ourselves a little bit on the back, but we're accredited by Adet Norska Veritas. We also have a rare designation of having ISO 9001 certification, worldwide reputation. And the reason we've gone with this organization, it has annual certifications where the minimum requirement is every 3 years. Well, we've chosen to be certified and accredited every single year. It's a little bit higher bar, but in one sense it's easier because we're always survey ready. We don't have to gear up every 3 years and dust off the place and so forth. We're always survey ready. We think that's better for the community. We also have, we're also a primary stroke center, and there's many other accolades that we could mention. One of the important things is to measure what we call hospital-acquired conditions, infection rates and so forth. We're very proud of the fact that we have among the lowest rates in the state, actually. We also, Pleasant Valley also did very, very well. The average for the United States is right in this area of the number of infections or other complications, and we continue to improve every single year. We also look at other measures compared to other hospitals statewide, and we are slightly below the top quartile of hospitals in both our preventable harm area and also our 30-day readmission. We're very proud of those scores. Sepsis and serious septic shock claims the lives of about 30% of patients nationwide who come into the hospital with serious infection. And our rate is a little bit lower than that, but we have a very focused area to bring that down and down and down. Many years ago, it was thought, for example, that a patient who was ventilated for a long time in the intensive care unit, about 5%, sometimes 7% of those patients would unavoidably develop a pneumonia. Well, now through very careful care bundles and a lot of research, we're able to minimize that. We have not had a single infection from a ventilator patient for approximately 2 years now. So we believe it is possible by gathering data, learning from others, sharing very openly what we might do to lower and lower and lower the mortality of patients who come to us with serious infection. This is a busy slide, but we're now doing physician registered nurse rounds by unit, and we were doing about 30% this time last year, and we've done more and more efforts. So now it's increasing. Sometimes our residents are involved in this, and what this does is it improves communication between the physician and the nurses to avoid problems and complications, and we're going to try to continue to get this up until the number is very, very high. But we're pleased with this growth. A lot of awards and accolades. I won't go through these, but your hospital is a very well-respected hospital from a quality standpoint, and that's the purpose of this slide. Our financial health, because this is our stakeholders meeting. We don't have stockholders, we have stakeholders. We have a very healthy balance sheet of assets of about $861 million and current liabilities of 77 million, wish it was 1,000. A long-term debt because we've paid down some of what we borrowed for the new building, but that remains high. And so our net assets, our equity, if you will, at $421 million. On the income statement side, we had a great year last year. Most health systems in California and throughout the state are suffering, and some of it deals with the declining reimbursement from Medicare and Medicaid, and the exchange programs we talked about earlier. There's less money to pay for providers, including hospitals. Our costs continue to go up. Salary costs, pharmaceuticals are going up by 10% per year, even generic drugs. And our increase from the government last year was 1.4%. And so this gap is hard. So we're among the most affordable hospitals in the state of California. We just instituted a program that we call Transforming for the Future. And we were able to save approximately $22 million and made a positive net margin as a result of that. So our operating gain, in other words, our profit from operations last year was $28.5 million. We had investment income of $8.2 million, some donations. And so we had a net margin or profit, if you will, of $36.8 million. And we added to our restricted donations of $3.5 million that are not included in that number. These are donations with a specific purpose, pediatrics or whatever. And legally, we have to use that money exactly as purposed by the giver, okay? Any questions on our financials before I go on? I know we're not accountants, but we're a very transparent organization where we want to share everything. Statistics, this is kind of fun to see. We had about 13,000 of us were admitted to the hospital last year. I was one of them, by the way, and I got great care. And I had a pneumonia on one side. And we had 2,700 births. We had outpatient visits, pharmacy prescriptions, almost 4 million prescriptions filled last year. Laboratory tests, 1.1 million. We provide laboratory tests for the hospital, our outpatient clinics, skilled nursing facilities. Many of them use our laboratory. This is the fun one, almost 2.5 million pounds of laundry. Thinking about all that ironing, you know, if you ever taken a tour of that, it's a huge place about the size of this room where there's this giant ironer and big washing machines. It's kind of fun to see. We provided, although the Affordable Care Act expanded the number of patients that have insurance, there are still some that don't have insurance, okay? About 10% in the state of California do not have any insurance. So we provided a combined about what is the arithmetic on that? $1.3 million of free care cost-wise to patients that did not have any insurance. In addition, we make up the gap between what Medicaid pays and what our actual costs are, which is not included in this. A building update quickly. This is just an aerial view. This is the new hospital right here. This is the current hospital. This is a picture that was recently taken of the front of the new hospital. Notice this mosaic I'm going to show, but this is a view from the new parking structure where you'd walk right across the street into the new building. This is a more close-up view of this mosaic Millard sheets that we relocated from. It was a legacy mosaic that we had for decades. We had it in a courtyard. We brought it up and over, and we're mounting in front. We're covering it with a UV protection, and below here is going to be a pond with a waterfall on the back to add a sense of nature with the sound of falling water and so forth. It'll be very beautiful. The UV protection also gives it a scrubbable value aspect so that if there is a graffiti artist, we'll be able to scrub it off, and they'll get their feet wet because they'll be standing in a pond. So a view of one of the elevated landings. This is on I believe the 4th floor. We decided to make a combination of modern and traditional with nice burled wood. This is one of the hallways, and it's long. It looks long, and it is long. The whole hospital is about a block long from end to end. This is a picture of one of the nurses' stations, another view of it. A lot of charting stations. Again, we no longer write things down. We use the computer to enter progress of patients' care. This is one of the ICU rooms, actually, from one angle. And this is just another picture of it. So we've used this very nice light wood, very beautiful linoleum. We decided to make it a very green building. And so we've used linoleum instead of sheet vinyl, recycled materials for the countertops, and double pane glass, a lot of glass. Every private room, all the rooms will be private, have wall-to-wall windows that overlook either the islands or the mountains on either side. And I've toured probably 100 hospitals in my career. I've never seen views like this, except for Queens Hospital in Honolulu. This is one of 3 pods for the neonatal intensive care unit, and it's huge, but taking care of the very tiny babies. This is just another view of the NICU, another view of that. This is an electrophysiology lab. Dr. Stan talked about this earlier. This is where the EP procedures like ablations would take place. This is one of the smaller operating rooms we have with the booms. We call them booms, or the suspended air systems and so forth. All the computers go and all the lights. The lights are the most state-of-the-art. This is the first hospital where they've been installed. There are about 300 individual lights on it, very bright. And each light has a camera on it, and it's connected to what we call our image stream system. Because we're a teaching hospital, surgeons can actually see a surgical procedure in an adjoining room and watch a surgical procedure going on while it's happening. This is all the rooms are similar design. We borrowed heavily from Celebration Hospital in Florida. A loved one will be able to stay overnight in every single one of the rooms. But the ICUs are a little bit different. This is a charting station for a nurse, and a nurse can see a patient. You can see the head wall there. A nurse can see a patient's face right there and acknowledge them, and then look through this window and see the next patient over here. This is just the inside of one of the ICU rooms. Not very impressive. This is the MRI. It's the most advanced equipment that's available in the world. And that's true of all of our imaging systems, our CT scanners, our cath labs, and so forth. The landscaping is also an important part. This is outside the dining area. And on a day like today, our employees and staff and visitors will want to eat outside. And so it's very, very welcoming. And some of the landscaping. The Ojai Hospital has been completely redone, and it now looks much more like downtown Ojai than it did with Rocky Mountain Stone era. And so it's a very beautiful design. We're also building a new hospital there, a 75-bed skilled nursing facility to replace our facility there. And this is just a picture update. This happened earlier in the week, where they're pouring the footings right now. And this just gives an aerial view. This is acute care hospital, our current continuing care center that is dilapidated. We need to replace it, and we're replacing it back here with a brand new facility. We've added some elements. I've mentioned a lot of the green elements of the hospital. We have decided to have art throughout the new building, and we've decided to use local artists. So we have a team of people, Susan Petty, Richard Ament, and Barbara Hirsch, are artists of their own right, and they have collected hundreds of pieces of art that will be in the main lobby and so forth, but also individual rooms, and the art will remind us of home where we are, since we're a community hospital. This is one of the pieces of art that will go actually behind the front admitting desk by Yoshimoto. And this is another example of art. This is going to be, this is a chemistry table. I was a chemistry major, so this is dear to my heart. But in the center, it's an HU for human. That we both have science, but we have human, and we're going to put this to remind our staff in the dining area. Some other pictures of our art from the pediatrics area, and so forth. So we're going to answer questions, but we're first going to invite Bill Kearney to come up and share a few words. And Bill is the vice chair of the Board of Trustees, and he's my idol and many people's idol in the community. He doesn't need an introduction, so Bill, would you please come forward, and then we'll answer questions afterward, please.
Thank you, Gary. My part is really kind of brief, which is cool for me and even better for you. I'm going to comment on where we are in terms of the fundraising for our new hospital. But I thought before I got to that, I would go back into history just a little bit and tell you how we got here, how we got to the point where we're actually raising money to build this beautiful facility that Gary went over. It was within the last 10 years that our Board of Trustees were investigating what to do about the California seismic requirements for California hospitals. There's all sorts of things that could have been done, and obviously the Board of Trustees looked at all of them. They investigated perhaps selling the current campus and building a new facility out in the east end of town. They thought about adding on to the current facility, or perhaps just renovating the current facility and bringing it up to the seismic requirements as they exist today. Thankfully, the board, in all their wisdom, looked at our current hospital and said, this hospital was built in 1960. It was built prior to any kind of imaging, certainly no cath labs, no MRIs, none of that. It was built before electronic medical records. It was built before the sophisticated lighting that Gary talked about, or sophisticated ventilation. It was clearly out of date. And the trustees decided that our community needed a Class A new hospital. And to me, with that decision, that's where the dream started. We as a community are blessed by the fact that the dream wasn't just for our new hospital in Ventura. This dream included modernizing and remodeling the Ojai Hospital, and it also included the skilled nursing complex that Gary mentioned, the continuing care center, and a rehab facility in Ojai that'll be available for the whole system. So here we are, we're now to the capital campaign because none of this came free. The Board of Trustees authorized the issuance of the bonds to build the hospital, but at the same breath, they also committed to the fact that our community would raise $25 million. 7 years ago, we committed to a campaign called the Because Campaign to raise that money. We haven't gone public with this. We've still been dealing with insiders, if you will, trying to get a good jump on what we could do for the community. Thanks to incredible generosity of our local doctors, our hospital employees, both foundation boards, our board of trustees, who, by the way, have donated 100%. There's 100% of the census that has committed to seeing this facility through. We have raised $24.1 million, which is an astronomical number for this community, and it's something I'm very proud of. My guess is that when we get ready to complete this dream, finish this dream of this new hospital, this updated health system, and we invite the public to enter into this, the number's gonna squirt right through the $25 million level. So I'm very proud to have been part of that. I'm proud to be associated with these two individuals, and they'll be very proud to answer your questions.
Well, you've been delightful, and Stan and I and Bill will be up here to answer the questions you have. Thank you so much for your interest. You've been a great audience. Thank you.